Medurstand-Understanding Medicine.
I am Professor Azizur Rahman, and today we are going to discuss some antihypertensive agents, their characteristics, their profiles, because in most guidelines they just mention different drugs, and I think if you know these drugs better, you can understand their application better. So this lecture is going to be like on applied pharmacology, and there will be mostly clinically oriented talk, but I will highlight the role of various antihypertensive agents and how they can be used in an individual patients. Now, coming to the numbers, first classification of normal tension or normal blood pressure. Even in the normal, we have various categories. The optimal category is the best one. If you are in the optimal category, I think you are the best off. Then normal category, then the high normal. Now let me define these categories. Now, optimal is if your blood pressure recorded properly with a calibrated apparatus with 5 minutes rest, and if your blood pressure is systolic is less than 120, diastolic is less than 80, both systolic and the diastolic are below these numbers, then your blood pressure is optimal. This is the best blood pressure to have. Then normal, of course above these, but if your blood pressure systolic is 130 or less and diastolic is 85 or less, so this is normal, 130 by 85, not 90, not 140. So 130 or 85 or less is normal. Then if your blood pressure is touching 140 systolic and touching 90 diastolic, this is high normal. You are still not hypertensive. Blood pressure is not in the hypertensive range, but it is not normal either. It is high normal. Various societies have identified this condition, they recognize this condition, but they have given it different names, high normal or pre-hypertension. So I think we need to understand that this condition is very likely to progress to hypertension if something is not done. And something at this stage is usually lifestyle changes. Acute coronary syndrome differential diagnosis. First of all, we have suspected acute coronary syndrome on the basis of chest pain, and the chest pain is prolonged and resting and ischemic in nature. So on that basis, we have suspected acute coronary syndrome, and let's see how we go further. Now, this is the pathogenesis of acute coronary syndrome. This is the normal vessel. This yellow is the atheroma, and this green part or blue part is actually the rupture which has attracted platelet, and somehow the clot is formed. That clot is rather small. Now if patient presents at this level and there may not be any infarction, this is the myocardium is ischemic but not necrotic, not damaged, and this would result in there would be no ST segment elevation. If you do ECG in this patient, there should be no ST segment elevation, and if you do troponins, they should be negative because there is no myocardial necrosis. So if there is no ST segment elevation and no troponins are negative, then it could be called unstable angina pectoris. Okay, provided we are dealing with ischemic cardiac pain. So ECG does not necessarily need to be normal. ECG could show something, but no acute ST elevation. And troponins are negative. There may be ST depression or ECG may look normal, and then it would be called unstable angina pectoris. Let's take the second example. Now, in this case, same pathogenesis, but somehow the clot is bigger and it has caused more critical narrowing, but not complete occlusion, and this would result in some myocardial damage. Now, because our coronaries are on the surface of the myocardium, they penetrate inward. So if there is a subcomplete occlusion, it is likely to cause ischemic damage to the endomyocardium. So the part of the myocardium which is closer to the inner surface. So partial thickness infarction of irregular size, and this may cause no, it may not cause ST segment elevation. Why not? Because the lead placed here would record ECG activity of this viable myocardium, and this part will not cause ST segment elevation. It might cause ST depression. So on ECG you will have no ST segment elevation, but since there has been necrosis, there would be the troponins would be positive. Okay, so out of acute coronary syndrome, if ECG does not show ST segment elevation, it may show something else, but troponins are positive. That would suggest the diagnosis of NSTEMI. That means non-ST segment elevation myocardial infarction. You could also call it non-ST segment elevation acute coronary syndrome. So let's take up the third category. In this case, either patient took longer to come to the hospital, or the patient was a little unfortunate. The clot was bigger and it almost completely occluded the vessel. So there was complete ischemia. This would result in transmural myocardial infarction. And this yellow indicates that myocardium is damaged through and through. Now, in this case, because of the current of injury, there will be ST segment elevation. So ST segment elevation and TROPS will be positive. So TROP will be positive whenever there is myocardial infarction. But when there is transmural infarction, only then ECG would show ST segment elevation. So this is ST segment elevation myocardial infarction. So this is basically the pathogenesis of different types of acute coronary syndrome. Complete occlusion would cause transmural infarction, partial occlusion would cause incomplete infarction, and non-transmural and minimal occlusion would cause just severe pain at rest. First of all, the most important, the pituitary dependent endocrine glands. So little introduction here. This is hypothalamus. Hypothalamus is actually endocrine tissue as well as brain tissue. It provides connection between endocrine system and the brain. We all believe that ultimately everything is controlled by the brain. So brain affects our endocrine system through hypothalamus. This is the hypothalamus, and there are various nuclei which produce secretory hormones and also inhibitory hormones. And then there are certain collection of neurons which produce actual hormones which are secreted into the posterior pituitary. Now, these secretory or inhibitory factors or hormones are produced by these nuclei, these neurons. They go to this portal system. The pituitary gland has this unique portal system. This is the portal system, arterial blood coming and passing through the lower part of the hypothalamus, carrying along all those stimulatory and inhibitory factors. Now they then go to the anterior pituitary. Anterior pituitary consists of various types of cells. All cells are specialized to produce a different type of hormones. Now these factors, they will either stimulate or will inhibit these specific hormones, and they will then in turn control other glands. So I think this is very delicate system. Then in the posterior pituitary does not secrete any hormones. It does not produce any hormone. It only collects the hormone which is produced by the hypothalamus. It just is collected here and then released into the circulation whenever needed and in just the amount that is needed. So this is the pituitary dependent endocrine gland system. One very important diagnosis of Cushing syndrome is made on the basis of clinical suspicion and lab evaluation. And we'll see how do we do that. As I said earlier, the best starting test is to do ACTH and cortisol. And we discussed earlier also, it is to be done in the morning at 8:30 in the fasting state. It can be done in the evening also, but best is morning. And I will let you think about these possibilities. What do you think if somebody has high ACTH and high cortisol? In the proper perspective, patient has clinical features of Cushing syndrome and you do these tests and ACTH is high and cortisol is high. Make a judgment. Where does ACTH come from? It normally comes from the pituitary. So the problem is likely to be in the pituitary. Another possible source of ACTH is a malignant tumor in the body. So there are two possibilities. Either there is hypersecretion from the pituitary indicating pituitary adenoma or an ectopic tissue, usually a malignancy. In both cases, ACTH will stimulate adrenal gland and will produce cortisol in excessive quantities. So the two possibilities are Cushing disease, that means a tumor in the pituitary fossa, and we will go for pituitary MRI. When you order pituitary MRI, you must specify that what you are suspecting. Only then the radiologist will be able to focus on pituitary fossa and will give you the right diagnosis. If pituitary MRI is normal or otherwise you suspect some ectopic malignancy, then you have to go for body scan. You have to image various parts of the body, but most common site of malignancy responsible for Cushing syndrome is lung cancer. So we would start with X-ray chest, and if X-ray chest is abnormal, we would proceed with CT scan or other imaging test. The second possibility, again, I will give you a minute, a few seconds to think about this. ACTH is low and cortisol is high. Cortisol is high, that is what is producing Cushing syndrome, but ACTH is low. So that means, what do you think? ACTH is coming from the pituitary. Do you think the problem is likely to be in the pituitary? No. In fact, it indicates that the pituitary is responding physiologically to an abnormally high cortisol level. So it is likely to be an autonomous adrenal tumor, usually unilateral or sometimes bilateral also. So adrenal tumor is producing cortisone in excessive quantities, and that cortisol is actually inhibiting pituitary in a physiological way. So ACTH is low. This combination of low ACTH and high cortisol should raise the suspicion of adrenal tumor. If that is the case, then we should image the adrenal gland with ultrasound, CT, MRI, or other tests. And third possibility is in a patient with clinical suspicion of Cushing syndrome, ACTH is low and cortisol is also low. Now, this is in fact the commonest situation. What do you think? How come you have this Cushing syndrome when both are low, when cortisol is low? Because cortisol is not the only corticosteroid we have. It is most likely to be an iatrogenic, because iatrogenic Cushing syndrome is caused by some non-cortisol corticosteroids, either dexamethasone or prednisolone. Now, these two corticosteroids, they have inhibitory effect on the pituitary, so they will suppress ACTH production, and then the endogenous production of cortisol will also be inhibited. But dexamethasone, which is taken exogenously, that is producing iatrogenic Cushing syndrome. So this is important because in our country, this is most likely condition. For example, these are two scenarios. Now, stage 1 hypertension, like 160, like 155 by 95, okay, that stage 1 hypertension with no additional risk factors on one hand, and stage 3 hypertension with multiple risk factors or with diabetes or with existing coronary artery disease. These two individuals are wide apart, so they need altogether different types of plans. So I think, and then we have all the grades and shades in between. Very, very important. That is why we always say that the treatment plan has to be individualized. Now we have to decide where this particular patient sits between these two extremes. Accordingly, we make a plan for him. We are continuing with this exercise. Interpret the finding and give your diagnosis. Pan-systolic murmur and mid-diastolic murmur at mitral area. So two murmurs, pan-systolic murmur and a mid-diastolic murmur at mitral area. Two murmurs in different timings of cardiac cycle. Most likely it is a case of combined mitral stenosis and mitral regurgitation. Pan-systolic murmur is caused by mitral regurgitation and mid-diastolic murmur is caused by mitral stenosis. A systolic ejection murmur on second intercostal space on the right side with radiation to the neck. Systolic ejection murmur best heard on the right side of the sternum, second intercostal space, and that radiates to the neck. Aortic stenosis. Yes. A click followed by a systolic murmur on the mitral area, the intensity increases on standing. This would be a case of mitral valve prolapse because the change in the intensity murmur with different postures means that there is variable component, and this can occur. The variable component is seen in Hockham and in mitral valve prolapse, and this of course a click followed by a systolic murmur and heard on the mitral area would definitely be in favor of mitral valve prolapse. Now, diagnosis is sometimes very obvious, but sometimes we have to go through this process, and I think it is always good to go methodically. First of all, we will take up the symptoms. Uh, we go this way. So first of all, symptoms may be very suggestive. Immediately after listening to the patient, we will examine the patient. So there are certain signs which are very, very helpful. And then traditionally, the first investigation of choice is X-ray, and X-ray is readily available and I think still very useful test. Although 2D echo or M-mode echo or just simply echocardiography has replaced many other tests because it gives you very detailed information. In some cases, where echo does not show classical changes or echo is not available, then NT-proBNP may be used. NT-proBNP will be actually useful to differentiate between heart failure and other causes of dyspnea. So I think that is the importance. So this is how we proceed in patient with heart failure. Diagnosis wise, we are going to take up all these topics one by one and discuss them in some more detail. Now, I think if you want to really understand the common features of these three shunts, you need to understand this picture. So I have drawn this two circulation, left-sided circulation in red, this is systemic circulation, and right-sided circulation is in the blue, which is pulmonary circulation. And there are three possible sites of defect. This is the intra-atrial septum, this is intraventricular septum, and this is between aorta and pulmonary artery. Now let's see first the normal circulation. I hope I am able to depict it correctly. So this diagram shows that whatever blood passes through the systemic circulation also has to pass through the pulmonary circulation. So although the systemic bed is much bigger than the pulmonary bed, but actually the volume of blood which passes through the systemic circulation is exactly the same as the one which passes through the pulmonary circulation, right? Minus few millimeters which comes from the bronchial vessels. So I think that you can ignore the blood, the left-sided systemic circulation equals right-sided pulmonary circulation, and there is no shunting. Now, if there is defect here in the intra-atrial septum, then some blood is coming all the way and going to the systemic circulation, but some blood will be actually reverted back from the left atrium. Instead of going to the left ventricle, it would go to the right atrium. Why it would do so? Because there is a shunt. Now, why it would go from the left to right? Because the pressure in the left side is higher than the pressure in the left side is more than the pressure in the right side. So there will be shunting of blood from the left atrium to the right atrium, and from right atrium it will go to the right ventricle, pulmonary artery, and lungs. So pulmonary circulation here is more than systemic circulation. How more? This would depend upon the size of the shunt. It could be 2 times, it could be 3 times, it could be 4 times. So depending upon the size of the shunt, the pulmonary circulation will be more than the systemic circulation. Now, if you take the example of VSD, ventricular septal defect, so the level of shunting is different, because this time it is from the left ventricle to the right ventricle, but everything else is the same. Blood is passing through the pulmonary circulation is more than that passing through the systemic circulation. And the blood which is shunting from the left to the right is oxygenated. Please appreciate this point. Blood in the left ventricle or left atrium is already oxygenated, and it will go through the lungs, will get reoxygenated. It cannot get more oxygenated because it is already 100% oxygenated. But the important point is that the blood whichever goes to the systemic circulation is fully oxygenated. So there would be no cyanosis in either of these conditions. Where there is left to right shunt, there will be no cyanosis, and there will be pulmonary circulation will be 2, 3, 4 times more than systemic circulation. Exactly same will happen if there is patent ductus arteriosus, except that the level is different. So I think I may not repeat the same statement again. So the same would apply here. Free T4 and TSH, they also have a reciprocal relationship. But in this case, this pivot point, the central point, the fulcrum is on one side, the TSH arm is much longer as compared to FT4 arm. And this is just like seesaw you must have experienced in your childhood. So in this case, you see if there is a reduction in FT4, only modest reduction in FT4 would lead to marked elevation in TSH. So there may be a situation where there is reduction in FT4, but FT4 free thyroxine is still within normal range, but FT4 would have gone much higher than normal. So that is why TSH is the most sensitive test. It is the first to become abnormal and last to become normal once you give them treatment. Okay, so FT4 is very useful, very sensitive test for patient with hypothyroidism, primary hypothyroidism. because when we start treating them, we have to repeat their thyroid function test many times. So that will add to the cost. So you could go for just TSH, and once patient is, in your opinion, euthyroid, then maybe you can have again complete thyroid profile, just to satisfy the patient that now everything is in control. These are some of the examples, the bone survey. Now you can see this is a very decent joint, but you can see this punched out lesion. This is actually a cavity. Now, how do I know this is hyperparathyroidism? I can't tell actually, unless I know the background. So if the patient has the proper context, then these cavities could be interpreted as a manifestation of hyperparathyroidism. Uh, these cavities. So there are other causes of these cavities. For example, metastasis could also present as cavities, but in proper context, these cavities would indicate uh, a, what is called osteitis fibrosa cystic. Luckily, these days, early diagnosis is possible, and I think no patient should go to this extent that he would develop these cavities. This is another cavity and punched out lesion. This is in the skull, and you know the lateral X-ray of the skull we also do in multiple myeloma. Very similar, but typical multiple, numerous punched out lesions are seen in multiple myeloma also. So you can make a proper diagnosis only in the proper perspective. And in this X-ray, you can see these bones. These phalanxes are, there is subperiosteal erosion. So you can see that these bones are eroded and narrowed down. There's something called lamina dura. This is X-ray of teeth, and normally there is a casing of bone here. This is the place where my cursor is. There is supposed to be a very thin bone here because it is normally paper thin. So whenever there is a resorption of bone, this may just disappear. So this has become famous as loss of lamina dura. This is, my picture is blocking it, but this is written loss of lamina dura. So normally there is supposed to be a thin bone folding like this, that is absent. So that is also a feature of chronic hyperparathyroidism. So that was all. Today's lecture focused on simple angina, and I discussed the definition of angina, William Burden's definition. Then I also discussed which points usually indicate a non-ischemic pain. Then we discussed the treatment principle, the medical treatment. The, we also discussed three main tests like ETT and thallium scan and coronary angiography. And then we discussed three treatments: medical treatment and angioplasty, and the most different coronary artery bypass grafting. But it's a dynamic disease. I hope I was able to give you some useful information about stable angina. We are going to continue our discussion on acute coronary syndrome, unstable angina, and some other aspects. Please do remember to join me again, and thank you very much for watching this video. And this is Professor Azizur Rahman from Medurstand. Thank you very much.